Hi there, I'm Jim Zirin. Welcome back for more of our conversations. Today marks the 200,000th death in the coronavirus crisis in the United States. Bill Gates recently said that the crisis has been mishandled by Donald Trump from start to finish. Where are we? Where have we been and where are we headed? Are the nagging questions. With us is Dr. Ian Lipkin. Ian Lipkin is the director of the Center of Immunology and Infection at Columbia University's Mailman School of Public Health. He's in a position to tell us. We're delighted to welcome Ian Lipkin back to the program. Ian, do you consider yourself immune since you've had the virus and you've recovered? I mean, what should those who've been infected and have had relatively mild cases and have recovered, what should they expect? What should their families expect?
We don't have a good handle on what immunity means in this disease. I think that in the event that I were to become reinfected, which is possible, as I say, we don't have a lot of information as yet, that I would probably have a milder case of disease than I had last time, because I do have some immunity. My antibodies may have dropped, but I have the memory of what it was like to confront this virus, and that should be helpful. So for all intents and purposes, we think that most people who have been infected once, particularly if they've had severe disease, are going to be at least somewhat immune to reinfection.
Now, I'm old enough to remember the time of the polio virus. And before the Salk vaccine was developed, there was something called gamma globulin, which probably still exists, which is supposed to boost the immune system or the resistance to the virus. Do we have anything like that for the coronavirus?
Well, it depends on when you'd have collected the gamma globulin. So if you're talking about a general collection from the population at large, and it's before the introduction of COVID-19, you're not going to find antibodies, for the most part, directed against this virus, unless you're sampling people who've come, say, for example, from China or Europe before it really hit the United States. On the other hand, there are collections of plasma that have been made since we've had the coronavirus, and there are a number of convalescent plasma trials that are now in progress. In fact, we are running one presently, not in New York. We started in New York. We moved it to Brazil. And there are two parts to that. One is for people with severe disease, and one is for people who have very mild disease who are only just beginning to manifest some sort of symptoms. So the first study was supported by Amazon. The second one, I just learned today, will be supported by the Skoll Foundation.
Skoll Foundation.
Yes.
Well, that's
Jeff Skoll. Do you know Jeff Skoll?
I don't know Jeff Skoll, but I now believe him to be a great philanthropist based on what you've just told me.
He's a very interesting man. So he was the first president of eBay. And after
so
eBay,
we have Amazon and eBay. They're the ones.
Yes,
now,
Amazon and eBay.
In light of the virus, they're the ones who are rich enough to fund further studies.
And Gates too. I mean, but all these people come out of this modern era. So Skoll is a very interesting guy. Not only has he supported this kind of work, but he's also made a major commitment to control of COVID. But in this case, he's really investing in trying to find solutions and to get at the real science, because there are plasma trials that are underway now that are not randomized control trials. And I think it's important, if we have a chance, we can talk about what is meant by a randomized control trial, because it's one of the major advances, I think, of 20th century experimental medicine. Prior to the time that we did these randomized trials, a physician, a scientist would say, you know, this makes sense biologically, let's see if it works. And they would give people one experimental drug or use a test or something of that nature, and they would see whether or not they thought there was a difference between the population that saw the intervention and the one that didn't. But there were decisions that were made, sometimes, you know, unconsciously. I've got this person in this trial, instead of moving him into the group that gets the drug because I think he's too sick or because he's not sick enough, I'm going to move him into this population. So with a randomized control trial, you decide what you're going to do before you do it. And then as people commit to the trial, they are assigned by chance into this arm or that arm. So there isn't any experiment or bias. So it's beyond what we think of in terms of double-blinded trials. With double-blinded trials, neither the physician or the experimentalist or the person who's getting the intervention knows which arm he or she has gotten. In addition, here, we're removing the decision-making process about who gets the intervention, who doesn't, from the investigator and giving it solely to chance. So it's very clean experimental design. And when you complete that, assuming you've designed it properly, you really know whether or not there's been an effect. So at present, we think that plasma therapy, people who have antibodies directed against this virus, can be useful, but we don't really know. And the only way we'll know is when we finish the randomized control trial.
So if your blood plasma were to be extracted and then in some way doctored up so that it could be injected in me, you're not clear that I would get immunity from or any benefit whatsoever from the injection of plasma coming from someone who previously had been infected.
That's what I'm saying. There are two reasons for that. One is we need to know that I have antibodies that can neutralize the virus and kill the virus. So what we're doing in this trial is we measure those antibodies. We don't just look for antibodies that can detect the virus. We look for antibodies that can actually kill the virus. We measure those, we make sure that they have a certain quantity and concentration, and then we introduce those into the trial. So it's a very complicated process to do this properly. But when you get to the end, you have a real answer. You know what you're doing.
So would the end product be a therapy or would it be a vaccine?
Well, that's an interesting question.
And what's the difference?
What's the difference? So a vaccine is typically thought of, we talk about active vaccination and passive vaccination. An active vaccination is one where you give somebody some component of the bacterium or the virus or the toxin as a, basically as an immunogen, and you wait for them to develop a response to it, which then is protective. It may not prevent you from getting an infection, but hopefully you should at least mitigate disease. With passive vaccination, what you're doing is you're taking immune components from somebody who is immune, putting them into somebody who isn't, and then protecting them that way. This would be a passive vaccine because I'm introducing something which has its own activity. You don't have to do anything except be the recipient of my immunological largesse.
What about safety? Is there a difference in safety between injecting someone with an active pathogen and a synthetic pathogen?
Safety is it has so many different facets to it. When we first began talking about vaccines and about giving antibodies, not that they're the same thing, there was a lot of concern that they might actually accelerate disease, that they might result in an aggravation or an earlier, onset of disease. We just didn't know. I think we can say now, based on the studies that have been done, imperfect as they are, that we don't see any evidence yet that this is a major problem. I can't say that for the vaccines because it's still too early. But with the plasma therapy, I think we have not seen any evidence that it makes things worse.
So how close are we to a plasma therapy that's safe and effective? And how close are we to a vaccine that's safe and effective?
We have infused 73 people with convalescent plasma in New York before the pandemic moved on, using this randomized control trial that I say is sort of the ideal approach. In Brazil, we've already treated 54 people. Our statisticians made a decision when we began this project that all we needed was 100 subjects. 50 received the convalescent plasma and 50 to receive normal plasma. With the introduction of the drug remdesivir, there were additional wrinkles because some people got the drug, other people didn't. We had to boost the numbers up to 129. And because now we have 2 sites, we have to get to 200. I think we're about 6 to 8 weeks maximum away from knowing the results with the people who have severe disease.
But what is its application to the experiment that you're conducting?
So it was what we call a confound. It's not a good thing for us. What it did was, because some people, we were going to be unable to determine whether or not people were responding to the plasma therapy, the remdesivir, or the plasma therapy plus the remdesivir. So we had to increase the number of subjects so that we could take account of the fact that there was more than one variable. Whenever you do an experiment, you want one variable. If you have more than one variable, it's very difficult to disentangle the effects of the two.
I'll ask you to look into a crystal ball. I don't know whether that's fair to ask a scientist to do, but if you were to look into a crystal ball, when would you say we would have a safe and effective therapy? And when would you say we would have a safe and effective vaccine? Any time in the near future?
Well, I think we already have some safe and effective therapies for certain aspects of the disease. If you have severe disease, there's very strong evidence now that steroids that suppress the immune response will dramatically improve your prognosis. And I think everyone worldwide now has access to these types of steroids in any city or town, what have you. I mean, in certain parts of the third world, this will be a problem. But for the most part, you can get access to these steroids. And these are useful, not early in disease, but in the late phases of disease when people have severe illness. There is evidence that remdesivir is helpful as well, particularly early in the course. So that's another example of something that's useful. Though it's not a great drug, it doesn't have a dramatic impact. And if I had to predict the impact of passive immunotherapy, these antibodies, I think that they will be useful early in the course of disease, before the virus has had a chance to really establish itself in the body and sort of take over the machinery of the cell. So
when would we have a passive immunotherapy that is safe and effective?
There are several companies now, including Regeneron here in New York, that are testing cocktails of antibodies that have been produced in a laboratory and characterized that I predict will be very useful. We don't have the data yet because it takes a long time to do these studies. I think, so I don't want to be, to hang crepe and say this is never going to work. I think we have several options for people now that do make a difference. When we first began this, we didn't know about positioning people. We didn't know about steroids. We didn't know about remdesivir. We didn't know about plasma therapy. We didn't know as much about masks as we know. We didn't know about MER13 filters and the way the virus might become airborne and so forth. So there's been a lot that we've learned. We're in much better shape now than we were in March, for example. However, when I came back from China in January, everyone there was wearing masks, gloves, avoiding, indoor spaces and so forth. And
but you weren't infected in China. You were infected in New York City.
I was infected in New York City in a television studio. I know exactly when it happened.
All right, so let me ask you about a vaccine. Everyone is saying, when will we have a vaccine so we can reopen the country?
So it depends on what you mean by when will we have a vaccine. We have vaccines already. We just don't know which ones to take and whether or not they're safe and effective, which is a separate question.
All right, no one wants to take a vaccine that isn't safe or effective. So give
Jim,
me we have as to when I can get injected with a vaccine that's safe and effective.
Jim, we have over 200 vaccines in the world that I know of personally at this point. And there are parts of the world where people are giving these vaccines already. Now, what we are doing right now is truncating the process for the approval for the testing of the vaccines by telescoping the phase 2 and the phase 3 trial. So phase 1 is where we look for early side effects that might be a problem. And we've done most of those studies already. Phase 2 is where we look for efficacy. To do that, we have to either find volunteers who we give the vaccine to and then challenge them with the virus and see whether or not they become infected. And there is actually, with the movement for a while, it's begun to lose a little bit of momentum. It was called One Day Sooner, where people are going to do exactly this. And then the phase 3, where we look at larger numbers of people for safety and efficacy. And there we're looking for longer term effects. So a couple of weeks ago, I guess there was a lot of concern about one of the vaccines that was associated with this disorder temporally called transverse myelitis, which is, it sort of looks like multiple sclerosis, but it affects a specific level in the spinal cord. And after reviewing the safety data and the exposure data and everything else, the decision was made that it was probably not related. I don't know, I didn't review the original data, but I presume people knew exactly what they were doing when they made that assessment. Now, there are other long-term effects that we need to understand. Women who are pregnant, people who are immunosuppressed, all kinds of things of that nature. If we had a drug that was 100% effective, whether that's plasma therapy or an antiviral of another type, we will feel much more comfortable with the vaccines. But I am generally comfortable with the vaccines. My favorites are the ones that launch immediately from within the cell as RNAs, and there are a number of companies that are making those. So my feeling on this is that there will be vaccine before the end of the year in limited amounts that'll be available to a specific populations, people who are considered first responders, who are otherwise in good health, and we're less concerned about them having adverse events. In the first quarter of next year, you'll begin to see more information on testing in people who are less robust, people your age and even mine, maybe 50 and 25, for example, and we'll then be able to start getting those. It's going to take longer still for there to be enough vaccine to treat all of the United States, probably the middle of next year. And then we need to remember that we need to make vaccines available globally. And my prediction, since we're talking about crystal balls, is that we're going to have to do vaccines continuously because there will be waning of immunity, there will be new people who will be born, who will become susceptible, and we're never going to eradicate this virus completely. Not only because it will continue to circulate in people who don't get vaccinated, but because it probably will set up in wildlife and domestic animals.
Okay, so now let's look backward. You've undoubtedly either read Bob Woodward's book or you've heard the tapes of his conversations with the president when Trump, when he interviewed him. Do you believe that a different kind of response at the outset could have saved thousands and thousands of American lives?
I do.
And where did we fall short?
We fell short in several respects. And I think there's blame not only at the national level, but that's where I think most of it resides, but at the local levels too. So there were individuals who were talking with governors and with mayors, primarily governors, and saying we need to shut schools, we need to change the way we're reopening. That's more recent. So there are certain areas that we knew were very, very risky. Because when I was in China, still sort of at the end of January, I was already talking to people in Amazon about ways in which they could protect their executives and people who worked in their fulfillment centers and their drivers. So they were thinking about this and proactively began to integrate various measures to safeguard their workforce. Then I began working with the Directors Guild. I worked with the Democratic National Committee for their convention. And I even gave some sort of comments to people who were at one point trying to do something with the Republican National Convention. So we've known for a long time about many of the ways in which this virus spreads. And it was very difficult. I can't say that in this country we had leadership that was up to the challenge. But at the federal level, it was awful. I think people weren't listening to Fauci. I remember Nancy Messonnier at the CDC, who stood up and said, last night I had a conversation with my kids and said, life as you know it is not going to be the same. And, Ann Schuchat, also at CDC, and even Bob Redfield. So these people were sidelined. These are the experts who should have been front and center, we should have listened to. And we didn't.
And what about all the junk science and the false messaging that came from the White House? Did that
A lot of that.
And also the hostility to science, the refusal to wear masks. I mean, as a scientist, how did that strike you?
Jim, there are so many things about the current political climate that disturb me. This one I know better, because I'm intimately involved with trying to address the consequences of poor receipt of science and lack of implementation of these methods that we know would have been useful, but we should not have been caught flat-footed. When I was in China, Chen Zhu, the former Minister of Health, who's now head of the Red Cross and the Red Crescent, was trying to collect personal protective equipment from all over the world, masks and gowns and face shields and gloves and, various kinds of disinfectants. We didn't do any of that. So
how many Americans would you estimate died because we were caught flat-footed?
It's in the tens of thousands.
The tens of thousands. Now, also, let me ask you this: we're now reading that,
and let me say further, for the people who don't want to look at this in economic terms, it's cost us trillions of dollars as well that we could have invested in infrastructure. It's destroyed us culturally. The various institutions, we've lost a year of school. People have lost a year of their lives. We also have depression. We have the people who died who could not get into a hospital, who couldn't get care for cardiovascular disease or diabetes or whatever else, or stroke, for example. So, when we think just about the deaths due to COVID, we underestimate the impact that this has had on our lives. And this is not something that surprised us at all. I mean, when we made the film Contagion, we showed all of this.
Well, you were a consultant for that film, but let me ask you this. We're now seeing a surge of the disease in the United Kingdom and in Israel and perhaps in other countries, I think even in Brazil, which you mentioned. Can we expect a surge here in the United States? Can New York go back to where we were in March and April?
I hope that we're not going to go back to where we were in March and April. But do I think we're going to see a change in the incidence of disease? Yes, I do. Because as people begin moving indoors, as people stop using personal protective equipment, as they become tired of, doing what they've been doing to protect themselves, we're going to see a resurgence of disease. And so the question is, what can we do to mitigate that? Well, we can complete these plasma trials, so we at least have therapy, which we think may be helpful. We can improve our ability to do diagnostics. So I was part of a group that included Bob Darnell at Rockefeller and Mike Shalansky and Orly Shields at Sloan Kettering and Jeff Shaman and others, who tried to come up with a testing scheme for New York City so that we could rapidly bring ourselves back to where we'd be able to at least track what was happening across the city. And we now have a testing center down, it's not the Lower East Side, but the Alexandria Center, which is 30s, I believe. We're now beginning to focus on local testing, that is to say, on-site testing, point of care testing, so we can be more rapid in our response. We also need to trace, so that when somebody becomes ill, we can figure out who also might have been exposed, so that we can contain the infection before it spreads more broadly through the community. Just remember, it takes a single individual has been associated with outbreaks in a number of instances now around the world. So we cannot afford to be complacent in our approach to this disease until we drive it down to nothing. And that's going to require vaccines. I don't see any other way. And as I've said, if you consider the fact that the first vaccines are really only going to be available for a very select few at the end of the year, we're going to be looking at maybe a year from now before we have the kind of immunity throughout the whole population that we need in order to be feeling safe.
Okay, so I have a question for you because we've run out of time. This has been absolutely marvelous and very, very.
We always do, Jim.
We always run out of time. And we hope we run out of time on this program, but not because of COVID. But let me ask you a question, Ian Lipkin. Do you believe that the coronavirus crisis has been mishandled by the Trump administration?
Yes.
Yes. Thank you for coming by. This has been wonderful. Thank you for coming by. Tune in next week for more conversations. I'm Jim Zirin. Take care, be well, stay safe, and all the best.